Thank you, Christoph and Ravi, and thank you, Joe Buell and the other organizers for asking me to speak. I asked the projectionist if that's the revised talk I gave him this morning, and I appreciate if he put that up. I'm going to be talking about implementation.
That's the only one we have. So.
Okay, thank you. Implementation of innovative surgical procedures, operative procedures. And I'm going to try to answer these three questions. Have patients been harmed by new surgical therapies? What do we mean by innovative surgical therapies? And how should innovative surgical therapies be evaluated? Some of what I'm going to talk about comes from this paper that we published in the Journal of the American College of Surgeons 5 years ago. And one of the procedures we talked about in that paper was laparoscopic. Almost all board-certified surgeons. There was definite economic pressure for surgeons to begin to do this procedure. It wasn't considered to be research, only the melding of two safe procedures, laparoscopy and cholecystectomy, previously shown to be safe. And there was an unexpected outcome, a serious outcome, increased bile duct injuries, which have been going on for 20 years. And the question is, what could have been done differently? Interestingly, 3 randomized controlled trials failed to show an increased incidence of bile duct injury in laparoscopic cholecystectomy. And bile duct injury, the increase, was shown by registries, Southern Surgical Club, McGill University Registry, and by reports from centers where the complication was concentrated. I'll talk a little more about that in a bit. This problem continues today. You can see the date in the upper right, and all the surgeons in this audience can recognize what a high and serious injury this is, and that there is potential for lifelong problems for a patient like this. Living right liver transplantation, also another example of unexpected harm to patients, and more relevant perhaps to the topic we're dealing with today. Seemed to be an important advance in an era of donor shortage. Blending of 2 safe procedures. Does this sound familiar? No formal restriction on diffusion. It wasn't considered to be research. There was definite economic pressure for centers to start doing this, and there are unexpected problems. There were new donor issues as well. If it was introduced in a more regulated manner, would outcomes have been different? Now, we talked about this in our paper in 2003, but I think an extremely important address was given in Mumbai last March. Excuse me. I want to go back. Can you put me back about one more? By Russell Strong from the University of Brisbane, who was the first person to ever do a living-related liver transplant in 1989. And so when I was going to give this talk, I asked Russell for a few of his slides, which he kindly sent me. And this shows the very good results that have been achieved at the University of Hong Kong with living donor liver transplantation. But here are the results from the European Liver Transplant Registry, and up beside them I will put the results from the University of Hong Kong. And the point here that Russell was making is that single center series very rarely reflect the results that will occur when a procedure gets out into the community. And I have to take a little bit of exception with my friend Daniel Cherokee when he said that laparoscopic liver surgery was safe from putting up a whole bunch of case series and quoting the mortality rate from the sum of patients who died in case series, because there's no obligation to present bad results. We might actually have very bad results if we knew every laparoscopic liver resection that was ever done in the world or that has been done in the world. So you can't say it's safe from looking at a bunch of case series that have been published. This is what Russell Strong had to say. In summarizing the results of adult-to-adult LDLT, there are individual programs that are achieving highly acceptable results. Overall, however, there appears to be